Okay, as we get to the top of the hour here, we're going to get started. My name is Blake Lackey. I'm one of the internal medicine chief residents. It is my distinct honor and privilege to introduce today's speaker, a physician, scientist, educator, and most importantly, advocate whose career is a model of what it means to combine academic excellence with a deep commitment to health equity and community impact. Dr. Joseph Ravenell is an associate professor of both population health and medicine at NYU Grossman School of Medicine, where he also serves as the associate dean for professional development. His journey in medicine is as inspiring as it is impressive. He began his academic career at Amherst College, where he majored in neuroscience and English. He went on to earn his medical degree from the University of Chicago Pritzker School of Medicine. He completed his residency in primary care internal medicine at the Hospital of the University of Pennsylvania, and then pursued fellowship training in health services research at Weill Cornell, where he also earned a Master of Science degree from the Graduate School for Biomedical Sciences. He is a board-certified internist and a clinical hypertension specialist. But Dr. Ravenell's greatest contributions, and what makes his presence here today so meaningful, lie in his unwavering dedication to achieving health equity for underserved populations, particularly Black communities. His work has focused on bringing healthcare out of the clinic and into the spaces where people live and gather, barbershops, faith-based and social organizations. Through a powerful community-engaged approach, Dr. Ravenell and his collaborators have built a network of over 250 community sites. These efforts have educated more than 30,000 New Yorkers on hypertension, breast cancer, and colorectal cancer, screened more than 20,000 people for hypertension, and helped over 5,000 individuals connect to crucial preventative and clinical services. He has served as the principal investigator for multiple major research projects and trials funded by the NIH, CDC, and the American Heart Association, all of which have advanced strategies to prevent and manage hypertension and improve cancer screening in historically underserved populations. His impact has extended to both men and women, and his programs have shaped national conversations on health disparities. His groundbreaking work even reached the global stage through a TED Talk that has now been viewed over 1 million times. In recognition of a career devoted to health equity, Dr. Ravenell was honored in 2023 with the St. George Award from the American Cancer Society, a testament to his lifetime contributions towards reducing cancer disparities and improving outcomes for all. We are incredibly fortunate to welcome here today. Please join me in giving a warm welcome to Dr. Joseph Ravenell.
Good morning, everyone. Microphone on here. All right. Technology is not my strong suit. Good morning, everyone. It's such a pleasure to be here. Thank you, Blake, for the very generous introduction. It gives me great pause to stand here 17 years after I left UT Southwestern and to be here and to just hear Blake describe my journey. It's clear that I would not have been able to achieve what I have, what I've been fortunate and blessed to achieve without my time here at UT Southwestern. UT Southwestern was my first faculty job. Back in 2005, I was recruited here by Dr. Ronald Victor, a legend here, I know. But he not only had an incredible impact on science and health equity long before that was a coined term, he also had a very powerful impact on me and shaped my career. And so in 2005, after I finished my fellowship, I came down to Dallas. Ron brought me down and showed me, some of the barbershops that he was working in, and also introduced me to Dr. Shauna Nesbitt and Dr. Wanpen Vongpatanasan and Dr. Norm Kaplan. And after meeting those giants of hypertension, given my interest in Black men's health and in addressing hypertension health equity, the decision about whether or not to come was incredibly easy. And so meeting Shauna, meeting Ron, meeting Wanpen gave me the courage to then go and ask my wife, Karima, at the time, would you be willing to move from New York City to Dallas, Texas? And so after literally like rolling on the floor and laughing at me, she, just because she couldn't believe that I was serious, she actually came down with me, met the team and said, Joe, this is definitely the right thing to do. And so our time here in Dallas is time that we will cherish always. We had our first child here, who's now about to go off to college. So just to give an example of how much of how long it's been. But I'm incredibly grateful to Ron, to Shauna, to Juan Penn, and to Norm, who really were incredible mentors to me. And made it possible for me to do some of the things that I'm going to describe to you today. So I'm going to be talking about community-based approaches to disease prevention with a real focus on hypertension and colorectal cancer. So this slide here, I think I missed one. Just want to make sure this is the right version here. Okay, great. So this slide here is one that Ron actually introduced me to. And what it shows is the large disparity in mortality from hypertension between Black men and other groups. Unfortunately, these numbers have all increased since I started doing this work, and the disparities really have not gotten smaller. Since I was here, which is a sobering fact that we just need to continue the work that we're doing to make sure that all communities are able to have the opportunity to experience their best health. But the reason that we see this excessive mortality from hypertension in Black men is because hypertension is a very challenging disease to get our arms around in terms of clinical management. So there are many barriers that stand in the way of getting from elevated blood pressure to controlled blood pressure that include healthcare seeking behavior. Men generally aren't as good about going to the doctor, but particularly in communities of color, we can see lower healthcare seeking behavior for very well justified reasons. History of mistreatment, both in science and in healthcare, either historically that folks have heard about or that folks have experienced themselves. And in addition, often just a lower awareness of the need for primary care is a really important barrier for men who have elevated blood pressure getting connected to care. And then when we consider other really important barriers such as cost and access, and as I alluded to, medical mistrust, which is well-founded both in our work and in other work that has been done. But these barriers are ones that we actually can address. And so we have a number of incredibly effective medications to treat hypertension. But it's really a matter of how do we get those therapies into the hands of the people who need them. So this cartoon here shows, how we get from having uncontrolled hypertension to controlled hypertension. It requires partnership with a primary care provider. It also requires that those providers actually make the recommendations that need to be made for folks to make important lifestyle changes and also to take the needed medications. But then at the end of the day, we have to figure out what are the best ways for our patients to actually be able to comply and adhere to the recommendations that we make around medication and around lifestyle. So this really was a sort of guiding framework for how we might address the problem of uncontrolled hypertension in Black men. So this is work from the Dallas Heart Study that Dr. Victor was also, he was one of the authors of that study. But this shows that for Black men with hypertension here in Dallas, fewer Black men with hypertension were engaged with a primary care provider from the Dallas Heart Study that looked at thousands of Dallas residents, was one of the best done population health studies ever that really led to lots of scientific discovery and innovation. But we also learned a lot about communities here in Dallas. And so, really important to keep in mind that there's this sort of paradox where Black men suffer often disproportionately from primary care sensitive conditions, yet have lower engagement with our primary care for the reasons that we spoke about. And those are, again, important areas that we can actually target and address. So given that Black men utilize primary health care less than other groups, we were faced with the question, how do we reach them to try to address hypertension? And so we really started to work on this barbershop idea. Ron actually started to do this work before I came, but recruited me shortly after starting it to really move this forward. And so the barbershop is an incredibly important institution in Black communities. And I know from personal experience, going to barbershops with my father, it was a place that we would go every 2 weeks where we would see the same cohort of men that I got to know very well, and got to hear some conversations that maybe a 7 or 8 year old shouldn't have been hearing. But the one thing that I learned was that health was something that was talked about a lot. And it was because the barbershop was a place of safety, a place where the customers came to not just be with their friends, but their barbers who we learned from the Dallas Heart Study. Black men actually, on average here in Dallas, had been with their barbers for over 7 years. Now, if you think about that, that's longer than most relationships that many people have. And so, you can imagine going to your doctor every 2 weeks going to your barber every 2 weeks over a 7-year period. You really develop trust. And we know that barbers are perceived as key opinion leaders in Black communities. And so it was said to me by one of our barbers that Black men trust their barbers more than they trust their doctors. And again, if you look at how often Black men go to their barbers compared to how often they go to doctors, it absolutely makes sense. So, growing up, I certainly understood the importance of this institution. And so when I got the call from Dr. Victor to come down and check out what he was doing in our barbershops, really looking at it as a place where we could educate and increase awareness of hypertension among Black men, this group that is disproportionately impacted, I jumped at the opportunity and came down here, and together we actually were able to secure the first NIH-funded trial of hypertension-focused intervention in Black men. And so this is one picture of me in the barbershop meeting a customer while he's getting his haircut. And that really is the beauty of the barbershop space. So much can happen simultaneously, but what I had that many people who are seeing patients for the first time in a clinical setting, what I had when it comes to the customers is the endorsement of the barbers, these trusted key opinion leaders. So the idea that we were looking to prove was that barbers could measure blood pressure, could increase awareness of hypertension among hypertensive customers, and refer them for care. And so we actually taught myriad barbers how to measure blood pressure. We had a formal training actually with these fancy machines where the barbers learned how to properly position customers. They learned how to select the right cuff. They learned how to have them sit quietly for 5 minutes before pushing start. And then, importantly, they also were able to tell the men what the numbers meant. And if it was high, they actually referred those men to primary care. They had my number on speed dial, so when there was a hypertensive customer and they were reluctant to go, the barbers would put them on the phone with me. I could talk to them right there, establish a rapport, and actually get them in to be seen, which was an incredible closing of the loop. And so, again, the idea being that barbers would measure blood pressure, would refer hypertensive customers to their PCP. The PCP would then hopefully initiate therapy. And then, because on average, the men go to their barbers every 2 weeks, that's a perfect interval to actually assess the efficacy of the therapy that the PCP started, where they would go back to the barber for their regularly scheduled haircut, and they would get their blood pressure measured, and the barber could reinforce if they were doing well, or if they needed to go back to their doctor and say, hey, my blood pressure is not yet controlled, what can we do about that? And also an important interval to check in about side effects. We know that when it comes to adherence to antihypertensives, the two major barriers are cost and side effects. And we know that some of the side effects are ones that are that can be a non-starter when it comes to therapy. So we tested this idea, and this is an example of one of the interventions that we used during this study. This is an example of a role model story. So in addition to the barbers advocating for the men to go and get their blood pressure managed, the barbers also served as role models to help get these customers to come in for a care. And so we didn't want to place the entire burden on the barbers. So we had these posters that were often, almost the size of this screen that we could actually put on the walls of the barbershop that had key teaching points that we wanted to reinforce. And the barber, if they didn't want to at the time, counsel the customer on what to do about their hypertension, they could just point to a role model story to say, hey, this gentleman is just like you. Why don't you read this story, and then we can get you connected for care. So we were able to show in a randomized trial of 24 shops that this barber-driven intervention resulted in a markedly higher control rate among hypertensive customers in the intervention groups compared to the control shops, where there really wasn't much happening. When we think about usual care in a barber shop, when it comes to hypertension, it amounts to not much. But we did provide all the shops with educational materials, and we were able to show in this, really, I think, groundbreaking publication that there was a really important intervention effect, where in the intervention shops, they were significantly more likely to have their blood pressure controlled compared to those in the control shops. Now, we were surprised that there was actually a moderate effect in the control shops, and what we attribute that to is, in order for us to get an accurate hypertension prevalence, and in order for us to get a baseline hypertension control rate, In all 24 of the shops, we actually had to measure the blood pressure of every single person who came into the shop, again, to establish hypertension prevalence. And we did that in a sort of 3-month run-in period before the trial started. And so, again, if we think about usual care in a barbershop, to then insert this sort of change of someone in the barbershop every day for over the course of a 3-month period, measuring blood pressure, and probably not doing a good job of resisting the urge to also talk about hypertension and educate these men who clearly, would benefit from learning about hypertension. There was probably a small element of contamination, and I hesitate to sort of use that word because it has such a negative connotation, because of course, how could educating people about hypertension be a bad thing? But in terms of the science, we think this is why we saw a pretty moderate effect even in the usual care shops. But the ultimate result of this was that we were able to prove the concept that barbers could do this and that they could do it well. And this led to a number of other barbershop-based studies, including after I left Dallas in 2008. I went to NYU to continue to do some of this work, but also to see what are some other applications of this barbershop model. What we realized in thinking about, what are the other applications of this barbershop model, we realized that in some ways, we were training barbers to be community health workers. The community health worker model is, one that goes back, hundreds of years and has been used widely in international settings, but here in the U.S. there is a large evidence base that community health workers, i.e. people who don't have formal medical training, but people who are exquisite at communicating with a target community or a population, that they can be trained in sort of very specific skills related to discrete conditions. And so hypertension is certainly one of those, but cancer screening can be another one. And at the time, we realized that we were really implementing a social determinants of health framework where the health outcome, we can take any health outcome, but for the purpose of this lecture, let's talk about hypertension control, right? And so here in this column, these are the proximal determinants of that. Of course, what the patient actually does matters. And then there are what we call intermediate determinants that basically are the context in which the behaviors of the patient happen. And so those intermediate determinants include stressors and survival needs. That includes financial or housing or food insecurity. Medical care, of course, is determinative. Psychological resources and social resources. What kind of social support do folks have to implement the behaviors that will lead to optimal health outcomes? And then, of course, there are what we call the distal or macro determinants that are the sort of true context for the work that we do in healthcare. And they include, the sort of macro determinants listed here. And so, what we have learned over the years is that we cannot ignore these more distal factors because they do have an important impact on what the patient is able to do to achieve their optimal health. But we learned that the church or barbershop and then when we insert barbers or other key opinion leaders, that they can actually help to connect some and actually support some of these more distal determinants in order to allow patients to engage in these health behaviors to ultimately reach the outcome that we are looking to achieve. So these are some of the some photos from the field so this is a picture that I took when I was in in Dallas. You can see I had no gray hair back then. But this is one of our customers that we met in the barbershop that we were then able to have come and see us in the hypertension clinic here. This is another picture from a Dallas barbershop. And then these are some pictures from our work in New York City, which I will describe in a little bit. But this is one of my favorite pictures of me measuring the blood pressure of my barber, Mr. Dennis Mitchell, Denny Mo. And to me, this, you can see the big smile on my face because I'm happiest when I'm in this setting, in communities, delivering the care that needs to be delivered, where folks feel most comfortable. So we, when I moved to New York City, thought about what are some other areas that we can focus on, and it turns out that colorectal cancer is another important disparity that affects Black men, where Black men have a 50% higher mortality rate than white men. And that is due to many of the same barriers that we see for hypertension, right? So the main driver of the disparity in colorectal cancer that we see is lack of timely screening. And that all goes back to engaging primary care. Again, because in the primary care provider's office, that's where referral and recommendations happen. So, the same cost challenges, the same medical mistrust, applies here. Because ideally, someone who is age 45 now, it used to be age 50, but if they are of average risk, ideally they would be seeing their primary care provider who would recommend that they go get tested for colorectal cancer, and the recommendation would be easily implemented, where customers or patients would be able to get the screening tests that they could afford and that they were most comfortable with. But one of the additional barriers when it comes to colorectal cancer screening is what we call lack of navigation. So, even though the recommendation is often made in primary care doctors' offices, we know that ultimately getting screened involves other parts of the healthcare system, namely, the patient getting to a GI suite for a colonoscopy. Of course, there are other modalities as well, stool-based screening, and that the list of acceptable options is certainly growing. But there has to be a partnership with other parts of the healthcare system, with primary care, and there's often lots of onus placed on the patient to take the recommendation that we make in primary care, and to somehow make this screening test happen. But we know that patients can benefit from having someone actually take them by the hand and navigate them to where they need to go within the healthcare system. So we actually tested the idea of putting patient navigators in barbershops to identify men who were screening eligible, and then to literally take them by the hand and show them where they could go to get the care that they need for what they can afford, and one that is most feasible for them. So the idea of our intervention was for the patient navigators to be in barbershops to provide education about the need for colorectal cancer screening among Black men, to elicit whatever barriers there are, and then to assess readiness. You can imagine that for someone who's never thought about getting screened for colorectal cancer, to walk into their barbershop and say, hey, how about we go get this colonoscopy? Probably not going to have much success on the first go-round. And so we assess readiness so that the patient navigators know the areas that they have to address in order to get folks from pre-contemplation, right, which is when you're not even thinking about doing something, right, to contemplation, which is when you're actually thinking about it, to the action stage where you actually go through with the screening. And so these patient navigators that we were able to recruit and hire were amazing. They were, for the most part, from the demographic that we were looking to target. and they were exquisite at communicating with the barbershop customers because they actually came from that community. This work gave us the ability to actually go and recruit the folks who could have the most impact for getting men screened. And so what we were able to demonstrate through multiple partnerships, we worked in about 250 community sites that included barbershops, churches, social service organizations, and a number of community venues. We were in all 5 boroughs of New York City, and we were able to recruit men who were definitely in our target demographic. At the time, the screening age, the recommended screening age was age 50. And what we knew in New York City was that the sort of average age where Black men were getting screened was when they were upwards of 60. And so we definitely wanted to get to men earlier so that we could hopefully identify polyps or early stage cancers, really trying to address the challenge that we were seeing at the time of late presenting colorectal cancer. So we were able to achieve that in the age that we were able to recruit. This tells you a little bit about the men that we recruited. And then in terms of education, in terms of marital status, many of the men were disconnected. We had a wonderful dinner with some of the internal medicine faculty, and we were just talking about how important our partners can be for making sure that we follow through with recommended health care. So, the fact that the minority of the men that we spoke with were largely unconnected, we think is an important determinant of the outcomes that we see when it comes to cancer screening. Other data to just show this was a very disadvantaged group that we were able to recruit with an annual household income of $17,000. And this is for a household of 4. So, you can imagine how far that takes you. It wouldn't take you very far here in Dallas. Imagine, how far it takes you in New York City. And then we found a very high smoking prevalence, which definitely aligns with, some of the things that we found here in the Dallas Heart Study. But through this barbershop-based patient navigation intervention, we were able to show that the men who engaged with a patient navigator in the barbershops, they were 4 times more likely to get screened within a 6-month period compared to those who only had a recommendation from their doctor to go and get screened. And so this is another instance of showing that the barbershop can be a powerful place for addressing health disparities for hypertension as well as for colorectal cancer screening. And so while I was fortunate to be able to advancing this work in New York City, in parallel, Dr. Victor, he went out to California and really started working on refining the blood pressure barbershop model, introducing pharmacists as another interventionist that could be placed in the barbershop to address hypertension. So the idea was that barbers would provide screening, but then actually be able to refer hypertensive customers right there in the barbershop to a pharmacist who could actually start medications right away. One thing that we learned was that here in that first study, we learned that we lost many men between the barbershop and the physician's office, where many of the men who were diagnosed, many of the men who had hypertensive range blood pressure in the barbershop never made it to primary care to have their readings confirmed and or to be started on medication. And so putting a pharmacist right there in barbershops, and this builds on a large literature of utilizing pharmacists and other allied health professionals in managing hypertension. And so Dr. Victor did an amazing job of getting funded to do this work for a very large study where they were able to show that this intervention of getting hypertensive customers started right away on medications could result in a marked decrease in blood pressure over a year. And so what this slide shows is in the intervention group, intervention barbershops where there was a pharmacist who was helping to manage medications and getting them started right away, there was a 27-point drop in systolic blood pressure compared to a 9-point drop in the control shops where there were no pharmacists, an intervention effect of 21 millimeters of mercury. And I'm not sure how many hypertension trialists are in the audience, but you can attest to the fact that this drop in systolic blood pressure is unheard of for many hypertension drug trials. So this absolutely an amazing accomplishment and confirmation that this model can be effective if we line up all the right pieces. Another important part of this was there was a network of primary care providers to make sure that there was a place for the men to go after they had been started on medication to make sure that they were being appropriately followed and managed. And so, putting all these pieces into place is what we have learned is really, really key. We can't just target hypertension or really, any other sort of chronic condition at just one level. So if we have folks getting screened and getting referred in barbershops, unless we have those other pieces in place, those more system level factors, such as having a place, a primary care place for them to go that we have, sort of already built this referral network with, all those things have to be accounted for in order for us to see the true power of the barbershop model. Some other work done here was showing that the barbershop intervention in LA, if it were at national scale, could actually reach 1/3 of all Black men with hypertension, and 40% of major cardiovascular events could be averted. And this economic analysis showed that payers should be willing to pay about $1,400 per patient year enrolled in the program, where they can see a significant return on investment. Of course, those of us who are in the hypertension space know that we do far better for ourselves if we can prevent the awful consequences of hypertension, of stroke, heart disease, end-stage kidney disease. So I know that $1,400 sounds like a lot of money, but of course pales in comparison to the cost of one ICU stay as a result of a stroke or a major cardiovascular event as a result of uncontrolled hypertension. So again, just wanted to highlight that Dr. Victor's work was published in the New England Journal of Medicine. And it just reminds me of when I first came, Ron said to me, "Joe, we're going to get this work published in the New England Journal of Medicine." And so the fact that he was able to see that come to fruition was absolutely amazing. So what are the keys to success for the barbershop-based approaches? Closing the community to clinic loop, a multi-level buy-in and a team-based approach, and a community-centered approach that also addresses social determinants of health. And that reminds me of a really important point about our patient navigation intervention. We not only had the patient navigators to connect folks for the medical care that they needed, they also helped to address social needs. Again, an area where community health workers really sort of lead the way. And I don't have to tell this health equity audience that addressing social determinants is absolutely paramount if we are going to have success in moving the needle towards health equity. But how do we translate these research findings to real-world implementation? What I've described for you so far are efficacy studies. How effective is this intervention at achieving a given outcome? But it doesn't really tell us, what would it take to actually implement this kind of intervention in a real-world setting? And that's where implementation science comes in. And so I was very fortunate to have been approached by the Staten Island Borough President to come and do a demonstration project in Staten Island, where Staten Island is one of the 5 New York City boroughs, where it's about 10% of the nearly 500,000 people in Staten Island are Black or African American. And nearly 90% of all Black residents live on the North Shore here. And so the North Shore area has the highest prevalence of hypertension in Staten Island. And so when the Staten Island Borough President approached me, he happened to have seen my TED Talk, and he said, "I can't believe you're here in New York City. Can you please come over here and help us with this problem of hypertension that we have?" And so we had planned just before COVID to actually set up a demonstration project working with several barbershops and other community partners on a project that we would call Take the Pressure Off Staten Island. And so it was a 1-year demonstration project to increase awareness and treatment of hypertension, patterned after some of the work that I just showed, where the goals were to increase awareness, promote heart-healthy behaviors, and increase primary care linkage for customers who have hypertension. And to facilitate these goals, we would create a network of community and clinical partners. And so for this project, we basically built on this model to fortify it with a network of social service providers, also managed care organization payers, and then other facilitators such as pharmacies and social services. And we had this large sort of steering committee and this network to make sure that when we identified hypertensive customers in the barbershop, that we could address their social needs as well as their medical needs, and be thinking about barriers such as costs and access by involving payers as well as pharmacies. And so over the course of the COVID year, 2020, you can see that even though barbershops had been shut down, the ingenuity of barbers never ceases to amaze me. But they set up tents where they could continue to provide haircuts. And one of the most fulfilling parts of this project is we were able to help the barbershops reopen, provide PPE, and help to train them in how to safely give haircuts. I was reminded of just how awful of a time COVID was, and we had a chance to talk about that at dinner. But in New York City, at one point, 1,000 people a day were dying. And so, we look back at these men wearing masks and, all of the things that we did to finally get on top of the pandemic. I know that, some of those strategies have been criticized, but I can tell you from firsthand experience being at the epicenter of COVID that what we did was absolutely necessary. And this project was a great opportunity to see how communities were able to be galvanized again to advance health equity. So take the pressure off. Our goal was to measure blood pressure in 1,000 customers. And so in addition to measuring blood pressure in barbershops, we also were using a mobile van to go and provide screenings. And over that year, we were able to outreach to over 3,000 individuals at barbershops. We got 1,277 screenings done. 800 of those were elevated. 480 people had a diagnosis of hypertension, and over 700 of those people engaged of 700 people with elevated readings agreed to be engaged for further management and treatment. And so what this slide shows is the incredible need for what we were doing, where 30% of the customers that we measure blood pressure on were in the hypertensive range, but another 50% were in the elevated range. And so all told, 80% of the men that we screened had either hypertension or elevated blood pressure. And this is using the 2017 American Heart Association hypertension guidelines. And what we saw was that overall, the majority of the men had health insurance, but unfortunately, the majority also did not have a primary care physician. And so these findings again demonstrated the need for really not just addressing hypertension, but also addressing elevated blood pressure. We know, thanks to great work that's been done, including the work of Dr. Nesbitt on the trophy study, demonstrating that basically, those who have elevated blood pressure without intervention have a very high chance of progressing to frank hypertension. And so showing this large group of folks with elevated blood pressure led to us being able to apply to the American Heart Association that at the time, right in 2021, was looking to fund health equity research networks. And so the Restore Network, which includes NYU, University of Alabama at Birmingham, Columbia, Wayne State, Beth Israel Deaconess, and Johns Hopkins, as well as other partners, UCSF and Tuskegee, we were able to apply for this large network grant to address social determinants of health to prevent hypertension. Again, elevating hypertension prevention as an important goal, and seeing, can we translate these strategies for hypertension control to hypertension prevention? So these are the aims of the Restore Network: to partner with Black communities to mitigate the impact of social determinants, to develop and evaluate strategies to implement evidence-based lifestyle interventions, to disseminate findings to policymakers and stakeholders to ensure sustainability of hypertension prevention strategies, and to train the next generation of early career scientists in health equity and hypertension research. So these are the 5 projects of the network, including my own community to clinic linkage implementation program in barbershops to reduce blood pressure. I was proud of myself for the CLIP acronym. And the other studies in the network focus on different settings and different interventions, but all to achieve the goal of addressing social determinants to prevent hypertension in Black communities. So the aims of my CLIP study are to assess barriers and facilitators of adopting the CLIP intervention for hypertension prevention in barbershops, to compare in a cluster randomized trial of 20 barbershops with over 400 men, those with elevated blood pressure or those who have stage 1 hypertension that they're not yet on pharmacotherapy for. And so with the idea being that we would have 10 intervention shops and 10 control shops with hopefully being able to show that addressing social determinants as well as providing men with the education and support to be able to engage in therapeutic lifestyle changes, that men who were able to access all of that would be less likely to develop hypertension over 12 to 18 months. This is the overview of our implementation strategies, where we not only wanted to understand what is the context for the intervention that we're doing in the Staten Island barbershops, but also sort of testing the intervention that we would come up with in partnership with communities as well as barbers, and then to be able to evaluate what we're doing and the impact on the clinical outcome of hypertension prevention. So the intervention itself is actually something that we call barbershop facilitation, which is built on the idea of practice facilitation. So this is an implementation science strategy, basically where an external observer comes into a clinical setting and they observe what is happening. But looking at a workflow related to a specific outcome. So if we take hypertension control as the outcome, what a practice facilitator does is they come in, they look at the entire workflow from the minute a patient comes through the door to the minute they leave related to hypertension management and control. And so they look at the process and they're able to give feedback to everyone on the team about what's going right and what could be improved on. And then it's up to the team to implement those strategies, and we look at the impact of that over time. So we took that idea and actually translated it to barbershops, where we have a barbershop facilitator who looks at all the processes related to hypertension prevention, which in this case is primarily screening for hypertension and then counseling and connecting men to resources to be able to prevent hypertension, but happening in a barbershop as opposed to a clinical setting. And so we started this project back in 2021, where we did our pre-implementation work of working with communities and with barbershops to come up with an implementation strategy that ended up with this workflow that basically includes community health workers measuring blood pressure, and for those men with elevated blood pressure, connecting them to resources, but also hopefully enrolling them in our trial. And so this is a schematic of the randomized trial that we're doing. 22 barbershops, 11 shops in the intervention group, 11 shops in the control group. And basically all of the barbershops in the study get the same thing, except that the intervention shops get a barbershop facilitator as well. And so our primary outcome is blood pressure reduction at 12 months, as well as what was the likelihood of progressing to hypertension in the intervention group versus the control group. So this is the inclusion criteria for the folks in our study. But basically it's adults who have elevated blood pressure or untreated stage 1 hypertension. These are some of the variables that we are measuring. These are the clinical outcomes, blood pressure, of course, also some patient-reported outcomes, but a number of social and demographic measures as well. This is what is happening with the men once they are enrolled in this study. American Heart Association Life's Essential 8 really is the foundation for the educational intervention that the community health workers are implementing. And so it includes monthly check-ins with the enrolled patients. They review Life's Essential 8, assess need for clinical and social referrals, and a reminder about follow-up visits. So this is some of the data from our ongoing trial, but we were able to over 2 years recruit over 400 men to our study. We ultimately reached our target. this was a sort of ideal recruitment timeline. But what's important for aspiring researchers in the audience is that life doesn't always happen according to what you project. But as long as you get to the end goal, that's all that matters. And you can see that we had some fits and starts, but there was certainly a learning curve, in doing this work where we were able to recruit all 400 men over the course of 5 cohorts. And so this just shows the individual 22 shops and the number screened in green, the number enrolled in orange, and the number who were the number of folks who were screened who were not eligible or enrolled in a yellow. But if we just focus on the orange bar, right, these are the people who were enrolled. You can see again the learning curve where in almost a linear way, the community health workers really figured out how we can enroll these men. What's really important to note about this is, and again, along the lines of implementation science, how do we do this in a real world setting? Well, the community health workers are actually doing all of the on the ground work, including recruiting participants, collecting the data, delivering the intervention, doing the follow-up as well. And so what we're showing in this trial is that lay people can be trained to do this research and trained to do it well. And so, again, this is another example of the learning curve. And the yellow is expected versus purple, which is actual. In the first cohort, we were well below where we wanted to be, but by the 5th cohort, we far exceeded what we projected for the number of men enrolled. When we look at baseline data for enrolled participants, we enrolled 430, and you can see intervention versus control that we did pretty well at having 2 comparable groups, right in the blood pressure target that we were looking for. This is some of the data about our men. The education level, where 74% graduated from high school. The majority of these men are employed. Unlike, and similar to our work here in Dallas, a small number of men were connected with a lifetime partner. And again, we're dealing with a very disadvantaged group in Staten Island from the income numbers which you see here. The majority have health insurance, and one of the real areas that we are incredibly proud of is our ability to stay connected to these men over 12 to 18 month period. So if we just jump to this number here, the number of participants who completed follow-up at 12 months, 90% of the men, the community health workers, have been successful at recontacting and measuring their blood pressure. And we're on track to be over 80% 18-month retention, which again, anyone who does this work knows how challenging that is. And all credit goes to the community health workers for their persistence and the relationships that they have with their community. So these are just some examples of some of the co-branding that we do with our community partners. And just want to shout out the community health workers that we're working with. It takes a village to get all this done, and we're looking forward to the results of the study, which is going to be ending in the next month or so. But we could not do this work without all of our incredible partners, and advancing health equity really does require a multi-level, multidisciplinary strategy that has to include communities. So I thank you so much for your time and attention, and I think there might be time for maybe 1 or 2 questions, but thank you all so much.
Hi, Joe Robert Haley. Good to see you.
Bob, it's so good to see you.
Wonderful. Yeah, looking back at when Ron started all of this, I remember from the very beginning, his dream was, one, to show that it worked, which ultimately did, and it's tremendously gratifying to see what you've done with it now. You've really carried it to two more steps up. It's fantastic. But I remember his dream was to try to figure out a way to make this self-perpetuating.
Yes.
Proliferating, so that you didn't have to be pushing it.
Yeah,
I remember you mentioned that he really worked on trying to get health insurance companies to realize the benefit to themselves, the financial benefit of getting these things implemented in a whole community-wide,
Yes.
nationwide thing. There were some other things, trying to look for ways of barbers getting reimbursement in some way, so they have an incentive to do it, so it becomes simple. Is there any further development of that idea?
Yes. So great question, and it's so good to see you, Bob. There are still several Haleyisms that I quote to my mentees, and so, there has actually been lots of development of sort of strategies to be able to reimburse addressing social determinants of health. And so now there are, and unfortunately, it really varies from state to state. But there are now ways that community health workers can be reimbursed for addressing social determinants of health. And so, I mentioned that essentially, we were training barbers to be community health workers. And so one of the strategies that we are thinking about with payers, because at the end of the day, what we do in healthcare really has to be reimbursable. That's the only way to incentivize it and to make sure that it is sustained. But we're thinking about how can we leverage some of those community health worker payment strategies to try to translate to this barbershop model. So we're not there yet, but I do believe that we are making progress towards that.
That's the sort of thing that might actually close that gap.
Absolutely.
Congratulations.
Thank you so much,
Dr.
Bob.
Wesson next, and then maybe just time for one other quick question. And
Congratulations, a great model. And my first question was already asked. So my second question is, I think I heard mostly an emphasis on pharmacologic intervention. Can you tell us a bit about the lifestyle, healthy eating, healthy moving, a part of the intervention?
Yes, absolutely. So for the study that we are currently doing, we're focused on the American Heart Association's Life's Essential 8. And so, that includes, strategies to increase physical activity. And then, when it comes to preventing and managing hypertension, dietary strategies are so important, largely reducing sodium as well as increasing intake of fruits and vegetables. But basically, the community health workers, they engage with the men enrolled in the study every month, and they reinforce some of those strategies to make sure that the men realize that the only way for them to avoid developing hypertension is to really engage in some of those therapeutic lifestyle management changes. So thank you for that question.
So one more question, and then others, please come down and ask your question privately.
Sure. Romaine Johnson, more of a comment than a question, but I'd like to hear your thoughts on my thoughts, which are, I've been thinking a lot about health equity and inclusion and diversity, and particularly when you talk about high blood pressure in Black men, the way I'm starting to reframe this conversation in my brain is that these represent edge cases. Really learning how to treat high blood pressure in Black men represents all our assumptions about how you treat Black blood pressure in general in a population that's maximally constrained. And starting to change the way we talk about equity and inclusion and diversity, and using that framework, I think will help us over time.
So thank you very much for that comment. I could not agree more, particularly now. That said, I don't think we should, shy away from, talking about communities that have, specific needs. The idea behind health equity is every community having the opportunity to experience its best health. And I don't believe, so while In some cases, there is a sort of, there may be a one-size-fits-all strategy, but I do believe that tailoring our strategies, to make sure that the communities who experience the most disadvantage have the opportunity to experience their best health. I think we have to continue to talk about it and to talk about it frankly. But I completely agree with you that that much of what we're talking about is not unique to Black men. But I do think that it's important for us to continue to keep in mind that some communities are disproportionately impacted by certain health conditions. So,
Well, thank you, everyone. Thank you, Dr. Ravenell.
thank you.
It's wonderful.